red blood cells, if you look at, they contain hemoglobin that permits RBC carrying oxygen and carbon dioxide, both as we talked about earlier. And both the things, they are from the lungs, coming back from the lungs, going back into the lungs, taking the carbon dioxide with it. So when we look at the RBC, what does it comprise of? The RBC comprises of heme and the globin. So these two components, actually, they make a hemoglobin. So the hemoglobin is made up of, if you talk about the globin component of the RBC, then or the hemoglobin in shorter terms, then it is composed of two alpha chains and two beta chains. So if the globin is not really working well, then the patient would suffer from anemia. If the heme component is not well, then the patient would suffer from anemia. And what is the heme component? It is the iron basically in the heme, which is the most important thing. So that is why both the things, the globin and the iron, they are really important for that purpose. And that is why when somebody suffers, the actually, if you look at a very complexity of the things, you will see that if this is the RBC, there are two alpha chains and there are two beta chains, and then there is iron. This little tiny things is the iron molecules, which are entangled into it in the form of heme. So by that way, this heme group is a very important component of hemoglobin. By virtue of that, the whole molecule is not complete if this component is not there. So the functions of hemoglobin, we have already talked about it, and it is carrying both oxygen and it is taking away the carbon dioxide. In the female, the normal expectation is 12 to 16 gram per deciliter. In pregnant women, WHO has reduced it to 11 grams. Why? Because when they look at the prevalence of the anemia, they find that the actually the 90% of the women, their hemoglobin is 11 grams. So that is why they have taken this 11 gram. If it is below that, we label it as 11.5 grams, we label it as anemia. But then it obviously would vary depending upon which part of the gestational age we are talking about. Sometimes the hemodilution is more, so we expect low level, and then early trimester it is relatively better levels. So, if you look at the cycle, the way it is, a previous slide was showing a very complicated picture, and going back again. So there are many organs of the body which are taking part in the formation of the hemoglobin, and the process would start at the level of the kidney, and then this process, in fact, starting from the intestinal where the absorption occurs, and the kidney playing its role in the formation by virtue of erythropoietin, and then the degradation process is taking place in the liver, as well as storage process is also taking place in the liver. So by virtue of a very complex mechanism, this iron is becoming a part of our body. So what happens is, when there is a low level of oxygen, then a negative feedback mechanism starts, and then this stimulates the kidney, the juxtaglomerular apparatus. From the kidney, you all know from the undergrad level, and there the erythropoietin is produced. So erythropoietin is released in the circulation, and it acts on the bone. And at the bone marrow level, the pre-erythrocytes which are there, they are converted into the erythroblast and then the mature erythrocyte, a process which takes quite some time. So by that way, then that erythrocyte, which is normally taking about 5 to 7 days to form, that erythrocyte is then undergoes a degradation process after 120 days. So the total life cycle of RBCs is 120 days. So in 120 days, those RBCs, they perform their function, and then they start degrading. So so if you look at it, the erythropoietin, again talking about the same thing, erythropoietin is stimulating the erythropoiesis process, and pre-erythroblast then they are converted into the mature red cells, and these mature red cells, now they are the one which are going to perform the function. So these new RBCs, they are relatively immature, but with time they start getting more and more mature. So by that way, the nature performs this function. These aged RBCs, as I talked earlier, they are phagocytosed in the liver and the spleen, and there they are then broken down, and that takes almost about 120 days. But practically, at one go, some RBCs are being formed, some RBCs are being broken. So when the RBC breaks down, the hemoglobin is converted into heme and the globin, and by that way, the heme and the globin, the heme is again got into the circulation, globin goes again into the circulation, and this process goes again and again, and then nature gives a defense that majority would be utilized from the body's own recycling process. But then obviously some is excreted, and that excretion process is now making deficient. And in the pregnant women, a new body is coming into, and that is a fetus. So the requirement obviously would be more during these particular phases of life. And then similarly, young girls, when they are developing in the teenage group, their requirement again would be more because their body is developing and the demand is there. So if you look at elemental iron, this is the actual form which is iron is present, and it is present in many of the compounds. So its atomic weight of the iron divided by molecular weight of the compound will calculate what actual elemental iron would be present in that particular tablet. So from there they calculate the what is the available iron to the body. So we are not going into detail of that, but that is how this iron is calculated in different tablets. And more, I would say, quality assurance is maintained, more is the expected outcome. So the sources of iron, if you look at, the iron is either in the form of heme, or it is formed in the non-heme form. So that is very important. The heme form of iron is available in the meat and the different meat products. So that is to be kept in mind, that if poultry, fish, beef is a very rich source of iron, and same goes for the liver and spleen. So if you have to look at, like people would saying, take more spinach, more, palak zyada khao. So palak is not a very good source of iron because it's a non-heme form of iron. But then they are going to balance the meat by adding fiber to it. So a combination of meat and non-meat products, that is more vegetables, some fruits, some grains, they form a good source of iron. Now, uh, when we talk about which forms of iron they are, available, it is in the ferrous form. Ferrous form of iron is +2 oxidation state, and ferrous sulfate, ferrous gluconate, ferrous fumarate. You must be knowing about them all. Their only disadvantage is that the high doses of these iron are required, number one, because it's only 10% is being absorbed, and these high loads, they can cause gastric irritation. So that is one of the problem when the iron is taken in the form of ferrous form. So then there are other form, which is the ferric form, which is a trivalent iron compound, and that is +3 oxidation. And here it is chelated with various components. So the advantage of this form of iron is that there is no gastric irritation, and then there is proper demand and supply of iron is maintained without causing gastric upsets. That is the one of the advantages. So if you look at this, there's a long table, but what we are concerned more with is this age group, 9 to 13 years in the pre-menarchal age. The iron requirement in the female is 8 milligram per day, and then as she goes into the teenage group, the iron is demand is doubled, and then it is in the reproductive age, it's 18 milligram per day. She's menstruating regularly, so her demand is almost 18 milligram. What happens in pregnancy? The demand automatically gets doubled, and in the lactation again it gets reduced. So we have to keep in mind that this woman has to be supplemented with iron from the very beginning once she is overdone with her first trimester, because first trimester is sometimes difficult for tolerance of iron. So I think I stop for a moment here. Am I clear so far? And if there is any question at this particular time, one or two questions can be taken so that you don't go to sleep.
We would take questions from this chat room. अगर वो क्वेश्चन आएगा तो इस चैट रूम से आ रहा होगा।
अच्छा,
तो
so
अभी आप यहाँ पे चेक कर सकते हैं कि आपने जो
अभी
बात
नहीं,
की है, अगर
ठीक है,
क्वेश्चन आएगा तो यहाँ पे आप यू कैन रीड द क्वेश्चन फ्रॉम
okay.
हियर।
So far its voice is clear. So so let's move on. I think is that
क्वेश्चन आ रहा होगा मैडम,
but at the
बता
moment
दो।
I can't
हाँ, जैसे वो क्वेश्चन नीचे लिख डाउन
share
चैट
with
रूम में
Dr. Shaheen. So the forms of iron in the body are the iron is distributed in the body in the four forms. Now that is also something which is very very important to understand, that if you talk about the iron, the human body contains about 45 milligram of iron in the body per kg of the body weight. 45 milligram per kg of the body weight, and the various forms of this iron are the transferrin form, which is for the transportation purpose. Then it is available in the form of stored form, which is called as ferritin form. And then the actual working form, that is the hemoglobin form. 70% of the body iron is stored in this form. And then another 5% is stored in the form of myoglobin, which is in the skeletal muscles and the muscles of the heart. So that is the important form. The storage form of the iron is usually about 20% of the total iron, stored in the liver, stored in the spleen, and the bone marrow. And these storage forms of the iron are then utilized from time to time. Then the cellular tissue is various cells they contain for the enzyme functioning. About 5% of the iron is stored in the different cells, and that leads to energy production and your different metabolic processes. So this is the distribution of the iron. Maximum is stored in the form of hemoglobin, some in the myoglobin, some in the form of transferrin, that is transportation, and some is in the almost up to 0 to 300 milligrams in the form of iron stores. So we have to keep in mind when this iron is given, that how much iron would go where. And again, this is one of the same thing, that how this iron is stored. So each ml of blood, if you talk about, would contain about 5 milligram, zero point 0.5 milligram of iron. And that we have to keep in mind when we are transfusing blood, how much hemoglobin will be built up by transfusing 1 unit of blood. So, because that would show how much iron would be absorbed. So, this is the iron kinetics. Again, the revision of the same thing. That is, the iron is absorbed from the intestines. And if we take 10 milligram or 10 to 20 milligram of iron, 10% would be absorbed. That is 1 to 2 milligram of iron would be absorbed. Then it will be transported in the form of transferrin. Some would be lost in the intestines, and this transported iron, 75% of this transported iron would go in the formation of hemoglobin. 10 to 20% would be in the form of transportation process. In fact, I would say in the form of storage, and then 5 to 15% would be for the other processes. So this is very, very important to understand, that almost 75% of this iron is required in the form of hemoglobin. So physiological importance of iron we all know, and that is again repetition. But immune function, your cognitive function, the temperature regulation, the work performance, they are all dependent upon the iron. Those who are meat eaters, आप notice करें जो meat eaters होंगे उनको सर्दियों में कम सर्दी लगती है. जो vegetable eaters हैं, vegetarians हैं, they are more prone to cold. So because your iron is keeping the temperature up. So that is important, that your meat and your hemoglobin levels, they are more meat is taken. So हमारे यहाँ तो उल्टा है. It's other way around. We don't vegetables, majority of the people, they are especially pregnancy में तो they are myths. Some would not give them meat because they think ये गर्म होता है. तो ये गर्म और ठंडे का concept है, that has also changed the whole scenario. So, the function of iron is the hemoglobin. We have already talked about. So, hemoglobin is carrying both the function, oxygen carrying capacity as well as the excreting the carbon dioxide. And then energy production, myoglobin, which is required, and that is why people say when somebody is deficient in the iron, think of when you're transfusing them blood, a weak heart which is deficient in the myoglobin, then that weak heart cannot take up, and there you have to go for the some less 6 20 mg at least under cover of less 6. In severe anemia, one should be transfusing packed cells, not without cover of less 6, because that weak heart can fail. And the weakness is created by the hemoglobin per se, and also by the myoglobin, which is dependent on the iron. So physiological importance, again coming to that. So iron is required in many of the oxidative phenomena, and these different enzymes are dependent on iron. And then in addition to that, the storage form of the iron, ferritin and hemosiderin, they are the stored form of iron. So in that way, the iron gets deposited there. Now, when the iron is absorbed, we all know that the what is the best area where the iron is absorbed? I'm sure everybody would be knowing, but again for the revision, the duodenum and the upper part of the jejunum, they are the one. Any iron which can release the particular amount of iron at that particular any preparation which can release the particular iron in the duodenum and jejunum, that is the best form. Otherwise, any form which releases iron in the stomach is going to cause irritation. A form which is coated, there are sometimes coated iron available, and if these coated iron, if they are not really looked into where the iron would be released from that coated form, then probably that iron would not be absorbed and the tablet would be lost in the circulation as such. So that is important to keep in mind. And then both heme and non-heme iron, obviously diet contains both the components, so it is absorbed. And then this iron which was available in the ferric form, that is reduced to ferrous form. And this reduced form of ferrous form, I'll show you in the next slide probably, where very nicely they have shown that ferric iron is taken up, and this ferric iron is with the apoferritin, is taken up by the apoferritin, which is lying in the intestinal brush border, and then this is apoferritin then converts into the ferrous form, and this is the diagram I was talking about, that the ferric form is taken up by the intestines, and here it lies in the ferrous form. So initially the iron was bound. In the bound form, it releases its ferric form. Ferric form is released from the stomach. It goes into the intestine, in the duodenum. Then it is in the duodenum. It is taken up and it is converted into ferrous form. And then as it goes along, then it again changes into the ferric. So it's a little slow, please. So transportation in the mucosal cells, and iron is bound to plasma transferrin in the ferric form. And so initially ferric form, intestinal border, it goes into ferrous form, and then again converts into ferric form. So transportation is through. So this is it. So again, while it goes into the circulation, and binds with the transferrin, again it is in the ferric form. Okay? So ferric, ferrous, and then ferric form again. So this is how it goes on and on, this process. And so this means your body system also has to be in proper place. Your intestinal borders has to be in the proper functioning form to get this iron absorbed. And sometimes if there's some people who have got a malabsorption syndrome, their problem occurs that the intestines are not functioning, the cells are not properly functioning, and this whole mechanism does not get completed. So some of the iron remains deposited. The good part, now this is important, that the good component of the oral iron is that the oral iron is actually stays in the intestines. So the intestines, they work as a storage factory for this iron to some extent. And from time to time, according to the demand, this absorption is controlled through the intestinal border. That is important, and that is why it is a safer, oral form is considered to be a safer form of iron. But for some reason, if somebody cannot go for the oral iron therapy, which we'll talk about in a minute's time, only then the injectable form is a better form then. So it is excreted in the urine, it is excreted in the skin, it is excreted through the intestinal, breakdown of the processes, and then through the menstrual loss, through some chronic hemorrhage, the iron is lost from the body. So in that way, so this is again that complicated iron metabolism, which is being, showing the similar, the food, just going back to summarize the thing in this way, how the iron metabolism works. So this is the iron, and this iron was in the form of ferric form, whether it's the heme or non-heme form of iron, it was available in the ferric form. From ferric form, it got converted, entered in the intestine, remained in the ferrous form, and from the ferrous form, this got converted into ferric, and then it goes to erythrocyte formation, it goes into the liver, and there the metabolism occurs. So that is how the things go on. So with this background of the iron metabolism, which is very, very important to understand, we have to talk a little about the iron deficiency anemia. Anemia, is one thing which is very, very prevalent in our country. Somebody anemic, it means he is deficient in every aspect, starting from immunity to to normal functioning. So different types of anemia we all know about, and iron deficiency anemia is on the top of the list because our diets are deficient in the iron, and plus some people have got an excessive loss of the iron. So different causes of anemia, whether they are formation, whether they are hemolytic, whether they are thalassemic, that is proper utilization of iron is not taking place, but that is how it is. And there are many, many risk factors for anemia, and we all know that, we already talked about. In our country, in addition to other things, is repeated pregnancies is one of the factor, and taking an advantage. Family planning, we should all be thinking about from all possible aspects, from the maternal newborn health, in addition to country's health. So I always say, if you have to save your country, please go for the family planning, because a healthy mother and a healthy child is going to be the way forward. Sometimes a chronic kidney disease, especially the diabetic patients, the chronic renal disease is another contributing factor because the erythropoietin is not produced, because the hemolysis is taking place because of the platelet deficiency, and that way the things are the patients are suffering from anemia. So look at the commonest cause of iron deficiency anemia. I would say the commonest cause would be, I wish I could communicate directly, but the commonest cause would be the, I would say, low intake, the worm infestation. हमारे countries में सबसे पहले तो ये वाली बात है. In addition to that, there is blood loss, then there is a poor family planning, so there is increased demand. She's not recovered from the previous one, and she's having another pregnancy. And then there is a poor absorption. Some people, they have got malabsorption syndromes. So, and poor dietary iron is one of the commonest reasons in the developing countries. In addition to that, there are food fads. In addition to that, there are myths related to food. And as I said, meat is really not favored by many. Some don't feel like taking meat during pregnancy, that we all know. But then there are mother-in-laws who probably they don't encourage the meat intake. So then there are various the transportation problems can occur, and in that way the iron is not properly transported if the intestine is not really functioning well. So the symptoms of iron deficiency anemia, we all know that, so I don't have to go into detail again and again, but all kind of symptoms. I do remember women presenting with fits. So nobody knew why she having fits, and but basically she was severely anemic, which was leading to so much hypoxia that the brain stimulation was occurring. And this is way back in 15, 20 years ago. I do remember those two cases. We referred to neurology, and in the baseline we came out to know that she was severely anemic. No other cause was there. So it can go to that level. And if it's a long-standing anemia, then there is a spoon-shaped nails they form, and the problem. Just by looking at that, you can see she's a case of chronic deficiency. So important thing about this iron deficiency anemia is that how to diagnose. There are many ways, but simplest complete blood count is going to tell you if she has got a microcytic hypochromic anemia, which means small erythrocytes. She's a case of iron deficiency anemia. And the only differential in that particular scenario is she might not be suffering from the thalassemia. And for that sake, you have to look at the MCH levels. You also have to look at the target cells. They are going to guide. So peripheral blood film would be answer. But on top of everything would be the ferritin levels. If you have to find out any form of iron source, go for the ferritin. That is the best form of storage of iron. So because that is more stable form. So just go for the ferritin, and that is going to tell you if the ferritin levels are low, she's a case of iron deficiency anemia. If she's just got a normal ferritin level, this means she's a case of thalassemia where the iron is not properly being utilized. Okay. If you talk about the women, pregnant women in our developing countries, the prevalence of this iron deficiency anemia, 52% in the pregnant women and 42% in the non-pregnant women. So in the reproductive age group. Now, important thing to understand is every patient with iron deficiency does not present with low hemoglobin. In the initial stages, she would have iron deficiency, but hemoglobin would be normal. But subsequently, as it goes on, it will start manifesting as a low hemoglobin state. So that is important. That is why when you are supplementing with iron, you also have to think of that you have to correct the hemoglobin and also account for the stores as well. So cater to the stores also. Because why the stores also? Hemoglobin is one form of iron which is required, but then the iron is required in other so many functions as we talked about earlier. So iron stores have to be fully depleted. It has to be full. So again, the same application of the same style. So what is the daily allowance of iron? And before that, we have to classify the anemia. Anemia may be a mild anemia, which is between 10 to 11 gram hemoglobin, moderate anemia, 7 to 10 grams hemoglobin, severe when it is less than 7, and very severe when it is less than 4. So these two places here, the blood transfusion is the answer, while in these two stages, the iron injections or oral iron both can compensate. So the, the causes of anemia we've already talked about, and whether it is excessive breakdown, whether it is less absorption, or whether it is less utilization, all the ways it can happen. The important thing to understand is that the countries where the prevalence of anemia in pregnancy is less than 40%, there you can just give the iron for 6 months in pregnancy. 60 milligram of iron, elemental iron, along with 400 microgram of folic acid throughout 6 months. But where the countries where more than 40% prevalence of anemia is there, like a country like us, here you have to continue in the postpartum period at least 3 months. You have to continue the iron supplementation besides 6 months of iron therapy during pregnancy. So that is important to understand. And then there are many risk factors which are adding to the anemia in pregnancy. Ethnicity is one thing, your dietary habits, multiparity, obesity. There are so many other risk factors which can happen in pregnancy. So I hope you're not at sleep. We are doing, you are with me during this whole process because it's quite a lengthy presentation, and but I don't know how to, which part to take it off because every component of it is important. So the effect of iron on the pregnancy, every possible effect, starting from restricted growth to preterm labor to a growth restricted baby, all things can happen. And then sometimes a uterus which is anemic does not contract well. So a woman may have a PPH, a woman may have APH. So these things may also happen. So iron has to be given during pregnancy, and the requirement is the estimated requirement of 800 milligram extra iron over the course of one pregnancy. Throughout the pregnancy, it is actually, if you talk about 60 milligram per day, so ultimately you will have to go for almost about 800 milligram of iron throughout pregnancy. So when iron deficiency anemia, as the pregnancy goes on, the iron deficiency goes, the demand increases. So as the trimester wise, the demand of iron increases, and that is why the severity of anemia also increases as the pregnancy goes on. Okay? And so what to choose? Oral iron initially might be the best form. And when do you expect a change? In per week, you expect a change of about zero point 0.5 to zero point 0.7 grams per deciliter change is expected. But important thing is this change usually starts showing up after 3 weeks. Why? Because simultaneously breakdown of the cells is also occurring. So the reticulocyte count is the best way where within 7 days you can see whether the response is occurring. If there are more than 1% reticulocyte, if you're demanding for CP, go for the simple reticulocyte count. If the reticulocyte count is showing 1%, more than 1% increase, this means the iron has started working. So when not to take oral iron supplementation? When she cannot tolerate, very simple to answer, or she's very severely anemic and she's in advanced stage and she is not compliant. आप उसको कहते हैं वो उसमें से सिर्फ 3 दिन गोलियां लेती हैं and the rest of the day she throws it off. So or when you want to be sure that iron is taken. So other possibilities are if she is not responding. 7 days you did the reticulocyte count, so probably your diagnosis is wrong. You have given iron supplementation, but she might be having some other cause of iron deficiency anemia. So she might be having coexisting infection, she might be having malabsorption, she might be having some loss of blood. So think of why is she not responding. In that particular scenario, go back and reevaluate. When do we go for the parental thyroid? Parental iron therapy is when somebody is not tolerating oral iron and you want a relatively quicker response. Now, here people have gone into different studies have been conducted, and initially they would say oral iron and the injectable iron, they have got the similar kind of outcome at the end of the day. But now the studies are showing that the injectable form of iron is giving a much quicker response, and the probable reason for that is that oral iron is dependent on many factors for the absorption. The food, for example, phytates, they inhibit the absorption. So when exactly is she taking? Secondly, is she really compliant or not? So all these things, they make a difference. So how much injectable iron, parental iron should be given? It is depend. It's a very simple formula, and it is weight in kg into iron deficit. For example, weight is 70 kg multiplied by iron deficit is 2, and multiplied by 270 multiplied by 140 into 2.2, and then add on 1000 milligram for total iron stores. So that would calculate your total iron amount. This formula is available by every pharmaceutical company who give injectable forms. You demand for this formula and then you calculate the total dose and then divide it into in such a way that you give it over a week of 2 weeks time. So when do, this is another important, very important question, when to go for the blood transfusion? The blood transfusion has to be restricted as much as you can. Why? Because it is associated with so many side effects. So especially in this era when HIV is also common, when hepatitis B/C is very common, so try to restrict yourself. So severe anemia after 36 weeks for the first time, women may deliver any time, does not have much time for the hemoglobin to build up, you may transfuse them. Similarly, a severe anemia, any stage, less than 7 gram hemoglobin, or she's symptomatic, severely symptomatic at 7 grams, you can transfuse. But if it's very severely anemic, less than 4 grams, oral iron or injectable iron is not going to affect, so you have to go for the blood transfusion. Keeping in mind that anemic women has got a very weak heart, so you have to go for the Lasix injections. Diuretics has to be given to cover for that iron, the blood overload. So There are many studies, as I was talking about, related to whether the injectable iron is better, the oral iron is better. They have shown that the iron sucrose is much earlier effective in building up the hemoglobin compared to the oral iron, and it's safer. So I always say that why would a woman get anemic if she was taking oral iron? So in that particular scenario, you don't have to think twice. Put her on injectable and iron sucrose. And then there are different products available in the market. Just ensure that number one, are they carrying following an international standards for the transportation of that iron? If the storage was required at a certain temperature, is that storage ensured? And how many studies have been already been done locally to ensure the safety of that particular product? Because there are many companies that have started marketing, and but since this is a form where the allergic reactions, hypersensitivity reactions are expected, so in that particular scenario, one must make sure that you follow proper guidelines and go for the products which do not make you get into the trouble by creating more and more reactions. So you should always have your own data. Like when this iron sucrose started, I was the one who started this iron sucrose for the first time with Professor Ghazala Mahmood. And this study was initially started with 5 iron injections in the infusion, which was not, initially started giving actions. So we reduced to 3, and then again we reduced to the, and then finally we came over 2 ampoules in 100 ml infusion every alternate day was a very absolutely safe options. And now we are very confident, and all over Pakistan, people are using iron sucrose very confidently. But in view of many products coming up, generations, different generic forms coming up, I think we have to have our own data, and so that you can confidently say that I infuse 100 women, and with this product I got these many reactions. And this we are keeping in our daycare. We have kept a register, so there we confidently say this product is good, this is not good. So I think I urge you also to keep that register in your offices, in your hospitals, so that you can confidently say, I would not promote any single product here sitting in a tertiary care hospital, but what I would say is go for the quality and have your own data. That will pay you back at the end of the day. And with this, I thank you very much for the very patient listening. I was just thinking that I may not be able to complete this in a stipulated time period. If there are any questions, I would like to welcome.
डॉक्टर नील का क्वेश्चन है आपके लिए
Yeah.
प्रोफेसर